Welcome, Tim, and thank you for taking part in the DAS webinar on learning from COVID. My name is Ellen O'Sullivan, and I'm delighted to be interviewing Tim Cook today. You will have heard maybe from the introduction earlier that Tim is a consultant anaesthetist in a DGH in Bath, and also a clinical professor of anaesthesia at Bristol. Tim in the past has been known as Mr. NAP because he has been involved in so many NAP projects from NAP 3 up to now, not NAP 7, and they have driven widespread changes in practice in the UK and beyond. So we also know him now as Mr. COVID because Tim has been very involved in all aspects of COVID research and epidemiology over the last few months. I'd also called Tim a Twitter influencer. I didn't know that term till recently. I only heard of fashion influencers, but Tim has well over 7,000 followers on Twitter and very interesting topics. I would advise you to follow him on Twitter. But now, Tim, today I'm going to bring you back to when we last met, which was the 5th of March. It seems a long time ago now. And we were at the Airway Leads Day at the Royal College. And at that meeting, Al McNary, who was organising it, he changed the programme at last minute to ask Tim to come and talk to us and speak about COVID. And I think Tim had been following the epidemiology at that point, and I think for the first time we all got it, that he stressed how serious it was and we needed to get our house in order. And I would suggest that this spearheaded kind of the Airway Leads to go back and think about getting readiness and preparedness for what was going to hit us, and which did. So it was like a pivot point really for us all. So Tim, around that time again, I think you started to discuss the consensus guidelines on airway management for COVID patients. You and some DAS members got together and wrote those guidelines, and they were published in the Hub, which is the Royal College, the Intensive Care Society, the Joint Faculty and the Association in with DAS, and they all signed them off, which was an incredible achievement in under 10 days, I think, but it was very important. So I suppose my first question to you today is, that was written quickly. It was written because COVID was upon us. In hindsight, would you change anything or add anything to those guidelines, Tim?
Thanks, Ellen. First, it's a pleasure to be here. And I hope that I'm speaking to people from lots of nations. I really hope that the DAS webinar has brought in people from many, many nations. I think there's a great opportunity to communicate with people virtually. Before I answer the question, I'd like to pick up on your comments about the Airway Leads Day in, I think it was the 3rd of March. And yeah, we did change the programme, and I spent most of the afternoon first doing a presentation and then doing a Q&A on COVID. I think it was called COVID by then. And I think the really important message is how valuable the Airway Leads network was in disseminating information, not necessarily about that, but as it happened about that, but in general. And it's so the Airway Leads came out, the network was produced as a result of the NAP4 project, which is now at least 10, is it not, 15 years old? I think the Airway network, which was set up by DAS and the college, has been a real strength in the UK. And I know that there are efforts being made to produce it in other countries. And I just think that ability to disseminate information in a time-sensitive manner, face-to-face, was really useful. Going back to your question about the guidelines, yeah, so a group of us got together, and I think we produced a draft in 48 hours. We signed off that draft within about a week as the writing group. And I think it was then signed off by the 4 organisations within another 4 or 5 days, maybe a week. So certainly within 2 weeks, we had a document which was sent to anaesthesia, who have been fantastic in terms of turning around documents and producing almost immediate, the next day, publications, so that there's no delay, that 3-month publication delay that we used to. And so we were able to get information both on the Hub and also out through the portal of the Anaesthesia Journal very rapidly. In terms of its content, actually, I think it's probably stood the test of time pretty well. So those guidelines were very much focused on, this was a time, if people cast their minds back, when people were visibly and actively scared about what was going on. I say this from a position of weakness, as it were, because I was off work, or rather I was working at home for 3 months. But there was a genuine fear about the risk that we were involved in as airway managers, and the exposure that was inevitably going to occur to us. And the guidelines were written around managing critically ill patients, and we came up with this SAS acronym, so that was safe, accurate and speedy, by which we meant it was safe for the patient and safe for staff. That's about PPE and about using well-recognised techniques and making preparations. It was accurate. That means using techniques that had been tried and tested, and not using innovative techniques which had not been tested and which were potentially unreliable. And within that, we emphasised first up use of video laryngoscopy, first up use of second generation supraglottic airways, and the ability to do a front of neck airway very rapidly. And then speedy. It started as, swift. It was safe, accurate and swift, not speedy. It started as speedy. We thought that gave the wrong message. So the point was about being timely and achieving the goals in the first time attempt, but without excess hurry. So swift, not speedy. Can't edit that out, sadly.
Just on that note, PPE, I mean, there was the second publication on the hub that was really relevant. There was a lot of confusion, a lot of mixed messages with regard to PPE, but the hub also came out with some pragmatic guidance, I would have said, and I think you were involved in that guidance, Tim. Can you just, and has that changed as well? Because that's one of the difficult questions we still face every day, particularly as it becomes more endemic from pandemic.
Yeah, so Public Health England has had and the equivalent bodies, devolved nations, have had a fairly unenviable job. But I have to say that I think sometimes communication hasn't been perfect. And there was some complex and rapidly changing information that came out, which perhaps didn't communicate around PPE as clearly as it could have done. And I think it's relatively easy to understand PPE if one thinks of the modes of transmission of the virus. So if one thinks around the equipment that you have to wear to avoid contact with the virus, which is essentially gloves and a gown, and then if there are droplets involved, you need a face mask and an eye protection. And then if it's airborne or aerosol, so within 2 meters, and you're doing an aerosol generating procedure, then the mask needs to change to a FFP or N95 mask. And the gown should be long sleeved and fully protective. And although there's been lots of criticism of the guidance that the UK PHE brought out, in fact, the guidance is fairly consistent. I think much more consistent than many critiques suggest, with WHO, CDC and other guidance. So there's some nuance around the extent to which the disease is spread by airborne, spread by aerosols. Undoubtedly it's spread by aerosols, but the extent of that and the extent of droplets is much debated. But I think if you understand the modes of transmission and therefore the situation you're in and the types of PPE you should wear to protect against those particular modes of transmission, it makes it a lot clearer. There's only 3 modes of transmission and there's 3 types of protection. So if you're distant from the patient but you're in a COVID area, you want to wear contact PPE. If you're coming close to patients but not doing aerosol generation procedures, then it's droplet protection. And then if you're doing aerosol generating procedures, or they are generating aerosols by massive amounts of coughing and sneezing, then you need to have airborne precautions. And I think that's something that has been missed on the wards, the amount of airborne precautions that should have been taken. I can see you want to ask another question.
Yeah, just with regard to AGPs again, and I mean, I did a list yesterday where in the morning I put in a supraglottic airway device, and the theatre did in the anaesthetic room without, the airborne precaution PPE. In the afternoon, I went to another hospital, same thing, supraglottic airway, and they recommended doing it in theatre with all the full aerosol generating PPE. So I think supraglottic particularly, there's a bit of confusion around it now. Now, again, most of the patients were tested for COVID, so they were COVID negative.
Yeah, so the whole subject of what is an aerosol generating procedure is, again, highly controversial. The Australian guidelines, which are very good, have taken a slightly different slant on what they consider aerosol generating procedures from the UK guidance, which follows PHE. And essentially the consensus has been that all anaesthetic airway interventions are aerosol generating. And that really comes from non-interventional observational studies from SARS. SARS is a very different disease. So there's an association, generally there's an association between these airway procedures and healthcare workers getting sick. Now in SARS, the peak period of viral secretion is when the patients are at their sickest, when they're becoming critically ill and needing intubating. And that's not true for COVID, when that period of secretion of transmissibility is passed before they become critically ill. And so the risks are quite different. And what it's not based on research that looks actually on genuine aerosol generation, and even better on the ability to detect reproducible virus. So there is lots of confusion. There is research, so two things. First, we've produced some more guidance, some guidance for more directed at the endemic phase of COVID and published in Anaesthesia, which has come out in the last couple of weeks. And again, that's with DAS members and representatives of OAA and obstetric and paediatric associations. And that's directed more at anaesthesia processes. And within that, again, we emphasize the primary use of video laryngoscopy and quick, safe techniques, prompt, quick, safe, effective techniques. With a specific regard to supraglottic airway devices, placement of a supraglottic airway, removal of supraglottic airway is unlikely to be aerosol generating, but the research has not been done. The procedures around it, mask ventilation, airway suction, re-intubation, or intubation if you fail with a supraglottic airway, coughing and spluttering, may be aerosol generating. And so if the sequence doesn't involve any of those additional procedures, so if you can anesthetize somebody having pre-oxygenated them, they are apneic promptly, adequately anesthetized for you to put the supraglottic airway in, they don't cough, they don't splutter, you don't need to suction, you've not used bag mask ventilation, then our view is that that's not an aerosol generating procedure. And after the event, you can declare it as such. And again, when you remove the supraglottic airway, if those procedures, if they don't cough and they don't splutter, it comes out smoothly, and you don't need to bag mask ventilate and they don't need to use suction, then it's not an aerosol generating procedure. And providing the supraglottic airway is not leaky during the case, again, there's no more reason to think it's generating aerosols than a tracheal tube when it isn't leaking. The big caveat is that we don't know if these aerosol generating procedures even produce aerosols. So there's a nice study from in the American Journal of Respiratory and Critical Care Medicine by Nathaniel Gakeley, that's spelled G-A-E-K-L-E, out in preprint, where they looked at volunteers using NIV and high flow nasal oxygen and other modes of oxygen. And they looked at them in a hyperclean area and looked at aerosols generated during different modes of oxygen delivery. And the summary is that there's massive inter-individual variation in terms of the amount of aerosol generated, but coughing and deep breathing are the things that generate aerosol, and they're not affected by oxygen delivery, with the exception of NIV and high flow nasal oxygen, which reduce the aerosols. So they reduce the aerosols, and I think that's a really important paper, which will be much discussed. So that's
a very interesting one, isn't it? Because
and if I could just say also, there's some important work going on in Bristol, which I've been very peripherally involved with, which has already looked at intubation and extubation, and has shown some quite exciting results, which I'm not going to spoil here, but has shown exciting results regarding the extent or absence of aerosol generation. And the plan is to go on and look at that. So this is using particle size analyzers close to the patient's airway. And so I think we're going to make headway in terms of working out what aerosol is produced. And I think, so although there will be green pathways.
This is very important research.
Yeah, I think that there will be pathways in which people are now not using airborne PPE while they're doing area management. But as we go into the winter, and we'll probably revert to using airborne PPE, and we'll see more and more sick patients, I think that this basic research will hold us in good stead.
There are some interesting abstracts, I think, as well, which were shown, I think, at lunchtime today on this topic. Some bench work done on aerosol generating procedures. So I think it's an important area of research, isn't it, Tim?
Yes.
For the, hopefully, if the pandemic re-emerges, which unfortunately it's looking a bit.
Yeah, and I'd be delighted if other people are doing research. I just haven't seen it. It's really important.
Yeah. So Tim, in July you published a paper on the risks to health from COVID-19 for anaesthetists and intensivists. And can I ask, are anaesthetists and intensivists at increased risk? Is there a danger of complacency creeping in as well?
The short answer is that we're not at risk. So compared to others. So in April, I worked with Simon Lenane, who's a GP from Shropshire, and some other colleagues, and we did an analysis of healthcare worker deaths in the UK, which was done through getting information from Twitter and newspapers about healthcare workers as when they were reported to have died from COVID. And the analysis was notable for two things. First, it was notable for the fact that the vast majority, 63% of those who died, were non-white, so Black, Asian, minority ethnicity, if people want to use that term. I don't particularly like it. Compared to 21% of the NHS workforce and 18% of the UK population who are non-white. And so there was an excess of both immigrants or migrants to this country and of patients of non-white ethnicity. And then the second marked finding was that amongst all the deaths, and amongst 166 deaths, there were 31 doctors, and there was no anaesthetist, there was no intensivist, and amongst all the healthcare workers, there was 166. There was one intensive care nurse, but we were dramatically underrepresented. So anaesthetists are about 15% of the doctor's workforce, and we were massively underrepresented. So in terms of deaths, and then if you look at my colleague Amira Kosomovic, I'll get that almost right, has done a lovely editorial looking at deaths in healthcare workers, particularly with anaesthetists, and looking at the international data, that is the same. We're probably underrepresented. And then more recently, there have been serology studies. So there have been 3 studies. One is the SAFER study from UCL, done by Catherine Houlihan and colleagues. One is an Oxford study by David Eyre, I think also published in The Lancet. And the third one was a recent study from Birmingham, published in Thorax this week. And all 3 of those studies show an excess, so they show that hospitals are high risk for healthcare for infection. So roughly the risk of being infected as a healthcare worker is about 3 or 4 times higher than the community you work in. So in London, where the community rate was about 15% of the population, the in-hospital infection rate, the healthcare staff was about 45% during the surge. And in Oxford, I think the numbers were something like 3 and 10%. But anaesthetists and intensivists were low ranked in that. And so they were very low rates. And in the third study, they were specifically anaesthetists, or rather intensivists, were noted to be amongst the lowest in terms of people getting infected. And the cleaners and the domestics, those people involved in housekeeping, and the acute medics were people who are most likely to be infected. And I think there are 3 reasons. I think I've just about got time. I'm looking at the timer. Just about got time to explain this.
Yeah,
there are 3 reasons.
Got a minute or two, Tim. Yeah.
I think the first reason is that anaesthetists and intensivists, I think most intensivists are anaesthetists or have been anaesthetists. Someone will shoot me for saying that, but we're used to working in theatre, so we're used to working in an environment where the use of personal protective equipment or barrier equipment to protect the patient from us is normal. We're used to not touching the patient, staying away from the scrub team, putting on scrubs if we're doing lines, etc. So we're familiar with that environment and those details. Also, I think we were prepared, whether it be for whatever reason, whether it be the airway network in March or whatever, we were prepared and we made plans about the PPE that we needed. And irrespective or with PPE sanction, we got ready for what was going to happen, and we gowned up and we put our visors on and we put our masks on. And so I think that there's that behavior, there's that experience and the behavior and the equipment. And then the third important thing is that when patients are critically ill, they're probably not infective. So in contrast to MERS and SARS, MERS and SARS, there's a really good systematic review by Muj Sevic, I may have pronounced that wrong, where she's looked at the viral dynamics. She's a epidemiologist from Edinburgh, who provides very good information. And so she looked at a number of studies, and I think there are 11 studies which looked at the duration. So you can be PCR positive for up to 10 or 11 weeks, both from your sputum, from stool, even from blood. But the viable virus within that has only been detected in those 11 studies for up to 9 days, maximum of 9 days. So essentially people are infective very early in the disease, mostly up to day 5. By day 9, which is typically when they get critically ill, their infectivity is almost completely passed. And it may be that there's combination of those three things, so behavior, kit, and the epidemiology of the disease, or the dynamics of the virus, have been kind to us during the surges. Now, I would say that is a reason not to relax PPE, not to relax behaviors, not to say we don't need protection. It's to carry on with what we've been doing, because it's protected people who are at the very front line looking after these critically ill patients. So I think it's an endorsement of what we're doing, rather than a message that we've been doing things unnecessarily.
Thanks for that very, very interesting and I suppose reassuring information there. And as you say, no complacency, because what we've been doing has worked. But anyway, unfortunately, we could chat all day, but I think our time is up, Tim. But my last question is what do you do in your spare time, Tim? Because I don't know what spare time you've had over the last 6 months since we met at the Airway Leeds.
Well, I quite like photography, actually, and so the picture behind me is one of a beautiful.
I was going to ask about
of a cafe in Italy, and one of the reasons it's up there is that I love Italy. I love it on Umbria, and the idea of getting back there is something that I hope, in the next 18 months we can all look forward to returning to a rather more normal life than we have at the moment.
Well, I think you'll deserve a break in Umbria, Tim. And again, thank you very much. And thank you for all you've done for anaesthetists and intensivists in the last 6 months, all your publications. And I'd recommend a lot of you to go and read some of them, and particularly the latest on anaesthesia management guidelines for the endemic phase of COVID-19. So thanks again, Tim.
My pleasure. Thanks, Ellen.